Next, we're going to kind of go a little bit out of order. Dr. Nora is from Swedish here and has a case that he has to go to, so we're going to have him go now instead. So Dr. Peter Nora is trained at Tulane for medical school and then went to GW, George Washington University, for neurosurgery training, and then came out here and really kind of started the first high-volume DBS practice here in the Northwest outside of UW, and has been doing it ever since. He's my kind of partner in crime for deep brain stimulation for movement disorders, and he's going to be talking to us today about choosing a target for Parkinson's disease. So thanks a lot.
Great. Thanks, Ryder, and thank you to Francisco, too, for letting me sneak in so I'm not getting paged by the OR in the next, when I'm in the middle of my talk. So I'm going to move through this pretty rapidly, and really my topics are going to briefly go through some history, patient selection, targeting technique, and targeting selection. For those of you who come from a program that's high-volume DBS, this will be a review. For those of you who haven't seen much, I think it'll be helpful. I'll also be in the lab this afternoon. Please feel, I'll be wearing scrubs, obviously, but feel free to come up, talk to me if you have specific questions, nuances, etc. And we'll leave a little time for questions at the end today. So in brief, this is neuromodulated therapy. Again, not destructive therapy, which in the case of the nuclei in question is a good thing, particularly for the GPI and for the STN. If patients are selected well, you can attain excellent patient outcomes, both by objective motoric scoring and by patient satisfaction scores. It's possible to do this well in an academic program, hospital-based, even private practice, as long as you put the right pieces together. And there's a large reservoir of good surgical patients. About 120,000 patients have been treated with deep brain stimulation in the world, 65,000 in the US. We've probably scratched about 8% of the available candidates in a given year with all the programs right now. So still, even by a very conservative estimate, we are not doing a great job of getting to those candidates, which I won't go into too much, except to show you this slide. And this is part of what the problem is with DBS. It is viewed a bit as a cultural anathema. People have no problems with wires going into their heart. Millions of people now do. When we talk about wires in the brain, it's a different leap of faith. And I think there's a lot of misinformation about deep brain stimulation that even comes from our medical community and even some of our neurologists. Just for the sake of nomenclature, this slide's a little busy, but it shows in the coronal view the 3 FDA-approved targets for movement disorders. Those movement disorders would be essential tremor, Parkinson's disease, and dystonia. We're really going to focus on Parkinson's disease here, but as you can see, the globus pallidus internus, the subthalamic nucleus, and the ventral intermediate nucleus of the thalamus. This is highly schematized, but again, it shows basically the symptomatic relief associated with each one of those motoric problems. I put at the bottom dystonia because there seems to be on the written board every year a question, not the oral, but the written board, of what target to use for primary or genetic idiopathic dystonia, and it's the globus pallidus internus, in case people are still in the room working on the written boards. So some brief history. DBS has been around for a while, as you can see. Treating patients with either primary or secondary dystonia still requires an HDE and IRB approval. For those of you who are interested, always going back to when did this clearly become something that was not experimental, but became standard of care? It was way back in 2001 when a very large group of patients was studied using bilateral STN and GPI stimulation. This was published in the New England Journal. And it basically showed that there was significant improvement with these motoric scores and some caveats about who good candidates were with Parkinson's disease. And I'll reiterate this again. It's important to understand that as far as motoric scoring goes, and we'll talk about in a bit, deep brain stimulation plus best medical therapy is better than best medical therapy. It's often a debate that people have, but that has been proven in multiple studies. That again, DBS with best medical therapy does better in motoric scoring and many quality of life measures. Just for familiarity's sake, the primary scoring system we use for both motoric scores, quality of life issues, cognitive functioning is called the UPDRS, started by Stanley Fahn in created by Stanley Fahn in 1987. It's a standardized rating score to look at the severity of the disease and its impact on individuals. Whether it's DBS or pharmacologic therapy or any therapy for that matter, this is the scoring system by which success or lack thereof is measured. Primarily, we have focused on part 3, which is motor functioning of individuals with PD, but as time has marched on, there has been more scrutiny with all therapies on how they affect cognition, behavior, and mood. We'll talk a little bit about that again towards the end of the talk. Okay. Who makes a good candidate? Well, some of this is very, very obvious. I want to talk about the things highlighted in red. Normal cognition, absence of dementia, huge. And obviously there's some tipping point where someone goes from being quote-unquote normal by objective measures and then they change. Realistic expectations of good family support. And younger is better, but younger is not having the diagnosis for 2 months. There are obviously some syndromes that are really bad, Parkinson's plus, Lewy body disease, multi-system atrophy, that if you treat one of those patients with DBS, I will promise you they will not do particularly well, and the question will be whether the DBS is part of the cause of the problem. Having done people who do not have the diagnosis because it was just a delay, and again, everyone thinking it was correct from the movement disorder neurologist to the family, etc., they will usually get a bump in their performance motorically, and then they will go downhill at 6 months, and usually pretty rapidly. That's been my experience with 2 or 3 patients. What are the requirements of a DBS practice? Again, I think this is all pretty intuitive to everybody. Make sure you know how a frame works. You have an understanding of stereotactic or a frameless system also. Intimate knowledge of 3D anatomy and physiology, which we're going to talk about in a bit. Again, for those of you who have not, this is your first time with the experience with the anatomic part of this residence program, it's stunning. There's nothing quite like it anywhere. And it even helps me to sit in on these lectures, again, to go through the anatomy, the surrounding structures to the relevant nuclei we're working on. From a more programmatic point of view, I'm just listing the people who are members of Ryder and my team. And we have found that a program coordinator, someone who really acts as the ombudsman, the ringleader of this group of people to help act as the patient advocate, has been really, really important to successful and busy practice. So this is kind of a dismal cartoon from the New Yorker, and I want to suggest that I'm not worried about all you wonderful surgeons in here having to go out and tell patients what you did wrong, but I also want you to think of DBS, and if you're interested, in really trying to get the best and most excellent outcomes. Not good, but great, and I think there's a process to getting there, having done this for a few years. So we're going to move into the targeting portion now, and I use this term course targeting. When I say course targeting, it's people will say to me, friends of friends in neurosurgery say, we want to start up a DBS program here, and I hear it's really easy. You got this great stereotactic planning software. You see the lesion, you put or you see the nuclei, you put an electrode in there, and patients do great. And I would say that's sort of the course mentality. Yeah, I know where the ACPC is, and if I put the frame on so it sort of lines up with the lateral canthus of the eye and the external auditory canal. Oops, sorry about that. And then I got my stereotactic planning software. This just happens to be one I use. Ryder uses a different one. Francisco might use a different one. But I basically can plug in a formula. And these formulas vary. You can get them in the literature. Well, if I just make a mark on my AC and a mark on my PC, and I plug this in, it'll take me to my target for the subthalamic nucleus. And that's true. It will take you to the subthalamic nucleus, and this is what you'll get. And it's really not good enough to say, but I put it where it said it was supposed to go, because that's not really surgery, and that's when the robots start to take over. So we want precision targeting, because precision targeting is going to equal precision outcomes. And this is really, really important. And And I'm not saying that I have the answer to precision outcomes, but it's definitely been a process where my targeting has gone from the red to the yellow, and now I ultimately want to get it in the middle of the yellow. I'm not here yet. But I want as many, with every one of my patients, I want as many as possible to be just like that. So what is precision targeting? Well, let's look at all the potential things we have at our disposal. Well, we do have the ACPC line, and that's important. We've got MRI sequences which can advise it. We've got GPI versus STN, bilateral versus unilateral. Indirect targeting, which I'm not suggesting is wrong as a starting point, but we've got direct visualizing, seeing where the nucleus is. In certain centers, we have intraoperative scanning capability. We can actually see before leaving the room where things are located anatomically. And there in blue, I actually have three other things. Microelectrode recording, which has been the standard at many programs and continues to be. We have macrostimulation. We have awaken asleep, which actually advises a certain amount of what we're going to do. And I put so if you look at the blue, that's really physiologic targeting. If you look at the red, it's really anatomic targeting. So think of precision targeting as availing yourself of this menu. I'd like to have all this. I'd like to have my patient both awake and asleep, but I can't really have both. But I'd like to use all these different things in my menu to get me where I want to be. DTI tractography sort of lives within both worlds. It's sort of physiologic and it's sort of anatomic, right? Sort of does a bit of both. Now, I did a patient the other day, which was a ventral intermediate nucleus of thalamus deep brain stimulating electrode for essential tremor. Sort of the old-fashioned slam dunk case. She was a little cognitively delayed, but I thought we could really make a meaningful difference to her quality of life. And I'm sort of getting in this groove of doing patients asleep right now, and I thought this is sort of a good patient to do asleep, but I don't. It's VIM. It can be kind of a tougher one. I said I'm going to do it awake. Well, she sneezed during surgery. Never seen that one before, and she moved herself in the frame with a cannula in the brain. I wish I would have done that one asleep. So there's no perfect answer that I do it this way with these, and it's always with asleep. I know. I think you have to look and nuance patient to patient. I think great results can be achieved doing it different ways because there's no absolute answer on what needs what. It's just experience that takes you there. But let's talk about some targets. Here's an axial view, T2-weighted image of the subthalamic nucleus. Right? Very classic, would be very classic initial targeting that I would do for a patient. Let's talk about STN. Okay? We aim for the dorsolateral part of the STN because essentially it's anatomically and topographically represented here. This is really where we want our electrode to be. The more anterior we move, the more we tend to move away from sort of home run, and the more as we move anterior enough into sort of the cognitive and limbic issues, which we don't want with STN. What about macrostimulation with STN? So we've done our microelectrode recording, and we put our electrode in, and we now have a patient awake, and we can, again, advise our ultimate placement, realizing we want to move and do as little as we can, but we can advise our placement by stimulating. Again, this goes to the understanding these three-dimensional relationships. Also understand that everyone's nucleus is not the same. There are recurrent connections that are different from person to person. So again, you want to be as much as you can on anatomy. You want to be advised as much as you can on physiology. Right? It's just not sort of as simple as it goes here because that looks like where it goes. I'm still advised with microelectrode recording. Okay? With STN, there are very crisp borders usually in a well-placed target between the nuclei and when you're out of the nuclei. Between this nucleus and the substantia nigra. Why generally is STN sort of where it is today? It still sort of runs ahead of GPI at most places. Well, it's a volumetrically smaller target than GPI, so why would you want to choose something smaller? Well, it's sort of a very predictable recording physiologically. It's easy to see, especially on a straightforward T2-weighted image. The side effects during macrostim are pretty consistent. You sort of know when you're there. This next point, which is the early data suggests a more rapid reduction in L-DOPA and a greater reduction in bradykinesia is a little bit of a stretch. You might get to your best place faster, but you don't ultimately get to a better place at 6 months with STN versus GPI. And look, long and short, it's just a preferred target. People like it more in the United States using it, although there is now starting to be an upswing in the use of globus pallidus internus for Parkinson's disease. So this is a nice picture of well-placed globus pallidus internus electrodes. Okay? As I said, volumetrically about 2.5 times the size of STN, but we often talk about the sweet spot within the sweet spot, which is the globus pallidus internus within the internus, which is probably much more akin to the size of the subthalamic nucleus. It also has a topographic representation. Okay? And placing it in the GPI is very important because placing it in the GPE or internal capsule does not give you desired results, but that also can be advised during surgery with macro stimulation. There also is a set of physiologic microelectrode recordings, which, again, with practice, I'd say are very well defined. There are some very interesting things you can do in surgery, including phosphenes, a patient who's awake, actually having them report to you, I'm seeing starburst when you stimulate, which is not dangerous, but advises the location of the optic tract. If I have a patient asleep during GPI, I will open their eyes in a dark room and shine a flashlight, and you can hear the optic tract, the whoosh of the optic tract, which again advises location. So the optic tract is one of those anatomic structures during planning that helps you with placement, but it also can help you physiologically during surgery in both the awake and the asleep patient. Now, what does the data show about these two? Well, the best study comes out of probably national institutes in the VA, and there's some other smaller studies too that have shown that from a motor perspective and from a mood perspective, maybe there isn't that much difference. And when I say, Kuhn's study, so there's really not that much difference between these two in the big picture. Okay? And as I said before, most centers prefer the STN. They're just doing more of it. Okay? As time has gone on, two things have occurred. First off, it looks that maybe the STN does cause some more memory and cognitive issues at a greater or higher proportion than GPI does. Okay? And there's some speculation on why that is, but again, although the numbers are high, we're talking about a couple hundred patients. No one really has the complete answer with this, but it has advised a bit of how we make our decisions. So in getting to that, look, as I've sort of said in so many ways, really look at your patients carefully. Be careful. Placing it well is probably the most important thing, not whether you choose subthalamic nucleus or GPI. Two ventrals, not good. Two anteriors, not good. Tends to really get into the recurrent circuits of the limbic system. And you don't want a patient who says, thank you for the surgery, it's the greatest thing in the world, and they're hypomanic. Because the family will say, they're moving better now, we can't stand being around this person, can we turn the DBS off, right? You really, again, this is about the precision. You want in the yellow part of the target. These that I'm going to share with you now are really very empiric, okay? I tend to use GPI for older patients who I think DBS is going to make a big difference on, but I have some concerns about cognition, mood, etc. If they have really bad dyskinesias, really bad, and I'll show you a picture of somebody with really bad dyskinesias from a movie, I tend to stray away from STN because I've seen people get worsening dyskinesia or new dyskinesia after STN. Okay? And if they have bad dystonia as part of their Parkinson's disease, okay? Because it also can induce some dystonia, STN can. I actually choose STN still in a higher proportion than I do GPI. That might be because my patients are a little younger, okay? If I think that they've got a lot of akinesia or freezing because a not well-placed electrode in GPI, a little closer to the GPE, can seem to worsen that in my patients, okay? With severe tremor, I prefer STN. But I think it's just because the tremor gets better a little faster, not a little better at 6 months. Okay? The younger patients, and not that I'm trying to play psychiatrist, but if I've got someone who's got apathy or a little bit depressed that's well controlled, I think they do get a little kick from STN. Okay? Just 3 big points here. I put the bottom one in red because I think it really, I don't want to understate it. Really make sure that your patients have thorough independent screening by a neuropsychologist. There is some evidence that DBS patients at 18 months after surgery that's starting to emerge may have more rapid declines, a small, very small portion on the order of about 5%, may have a more rapid neurocognitive decline than those with best medical management. So we'll start to get into a debate of, well, they're motorically better, but their neurocognitive function is worse. Now, we know people with any kind of neurosurgery are at risk for that on the brain, right? But I think it's telling patients, their family, et cetera, there is some risk here on the order of 5%, that we could notice that there is what would appear to be a more rapid decline than if we just stuck with medical management. But you have to take quality of life in its totality, right? How they're doing motorically, et cetera. So I'm going to flip. I think I'm out of time, but I'm going to just flip on this. So, and this will sort of, well, if there's any time for a couple questions, this just shows a guy, one of my favorite patients, his life on the left before DBS, his life on the right after. He's got dyskinesias. In order for him to live independently, he's got to take Sinemet every 2 hours. That gives him dyskinesia. But he's not going to live independently if he's frozen. So this is him 6 months after surgery in his best on time with his medication reduced about 70%. So this is STN actually. STN. Okay, question, and I've got other videos, but I've already my time's already up. So any questions? Again, we'll definitely be around for questions in the lab for a couple hours today.
With respect to dyskinesia was because his medications came down a lot.
Absolutely. And again, some I didn't put in my slides. You know, the big four, the big three, which includes dyskinesia, are, and this is what I tell patients, let's forget about everything else, increasing your on time, reducing your motor fluctuations, reducing your medication. Everything else is cream after, if they're sleeping better, if they have less pain, if their mood's elevated, but I keep it very motoric. Right? Absolutely. That's really where this lives.
Cool.
Okay. Thank you.
Great.